To improve care for people with cancer, it should be part of what we do. Anytime we start a program, anytime we have a new intervention, a new clinical trial, or you just want to find a way to make things better, you should be thinking about research, and you're probably doing it, but you're not calling it that. So while this is about pediatric research, it's really about everybody. So I just wanted to make that point, that all of us are involved. What we know is from the time that someone has a intervention or a piece of a guideline or a treatment that they have found that's effective, it takes almost 17 years before that information is matriculated into normal practice, before it actually starts to benefit the patients that we are talking about and that we want to help. 17 years is a long time to wait. So what usually happens is there's an issue. There's something that people want to improve, change, modify, whatever. So we create an intervention to try to do that, and then we see the effect. That is what research is, right? Most of the time, unfortunately, from that 14% that actually make it into the population, only about 6% benefit is actually seen from that. So audience participation. Any ideas why, when we have something that we know works, why we don't see the benefit for our patients? What's going on? Anyone can shout out an idea. Cost. Cost is a good one. Why things that we know help don't get translated to our patients. Other ideas? Access to resource, training. So when you're looking at it, there's different things. One, the issue that you are trying to help may not be important to the group that you're actually working with, right? So it's important to understand what, for each hospital, for each division, for countrywide, is it something that is relevant to that population? If it's not meeting the needs for the population, or you're not addressing the barriers that are preventing people from seeking care, you're not going to get the effect that you want. Also, if socially, it's not going to be approved. So you need to understand culturally what's important and what people are interested in. And if the organization or the hospital doesn't think it's an important issue, whatever you try to add to the intervention, it won't be successful. The intervention itself, so you may not have resources, you may not have the providers that are there. The perception may be this is something that was developed in a totally different population. It's not relevant for our group. It's not relevant for Bugando. It's not relevant for Mumbili or another site. It wasn't developed locally. So that's something a lot of times people aren't interested in adopting. You have to have the key stakeholders need to believe the evidence that supports what you want to do. So if the key people don't think that it's good evidence or it was good research, so higher likelihood it's never going to go into practice. And the cost. And the other thing, something might not work because you were measuring the wrong thing. So you may be looking at outcome, but what you really should have been looking at is quality of life, or how quickly someone comes to presentation. You have to make sure that you're looking at the right measurement. So this is incredibly important for pediatric cancer. And the reason why is that we can cure over 85% of all cancer patients, okay? So for most of you that are adult oncologists or radiation oncologists in this room, that is a huge number. For us, that is the potential. So right now, in most low resource settings, that survival rate is probably about 20 to 30%, as been mentioned. Why is there this huge gap? So imagine if we can find a way to reduce that gap, the amount of patients that we can help, the amount of children that we can cure. And the ability to do this is something that some of you may have heard, and it's something that I think everyone should do, is something called implementation science. Basically, this is a research infrastructure where we know something works, someone has published it, whether it's a new way of managing medications, if it's a reminder system, it's an mHealth app, something has been shown to be effective. What the implementation part is, using strategies to adopt and integrate evidence-based health interventions into a community to improve patient care. This is what all of us do. We just don't call it science. We don't call it research. But all of us are finding new ways to help our patients. But what we're not doing it is we're not following along and we're not monitoring it in a scientific way that will help us prove to others that what we're doing really works. Put into a different viewpoint, this is sort of a model that you use where the first step is to go in and figure out what the actual issue is that you're trying to correct. What are the local stakeholders? Who are the people that you need to have their buy-in in order for something to actually work wherever you're trying to do the intervention, whether it's on the wards, whether it's with the nursing staff, or if it's through the whole hospital. If it's an intervention that has come from another hospital, another country, you need to find a way to adapt it to wherever you want to do the intervention, okay? So you cannot just take something and expect it to work in every different environment. Then, as you do the intervention, you have to evaluate. You have to have a way to show that what you're doing makes a difference. So if it doesn't, you need to continually go back and rethink about it, reevaluate, and monitor going forward what the impact is. That whole thing is kind of called implementation science, and it's a model that's very effective. So if you don't do the implementation science route, you take something, that's the 17 years it takes for a new idea to actually influence our patients. But what they have shown is if you start with this process, you start with understanding the problem, adapting it, implementing it, evaluating the response, you can have an 80% uptake of whatever the intervention or whatever the thing is that you are trying to introduce in 3 years. That's a huge difference. And all that it takes is thinking about the process from the beginning. So I want to kind of give an example, and this is what we've done at Bugando Medical Center in pediatrics. So we started with trying to understand what the problem was, what sort of the current outcomes were for patients, what the issues were, what was important to the hospital, what was important to the patients, what was important to the staff, coming up with what was needed, some different interventions that we could try, and then evaluating the response. And this is where we are. Bugando, so right at the base of Lake Victoria, which we were at last year. So historically, our 2-year overall survival for all patients was 20%. And this was back in 2014. We looked at treatment capacity. We had access to chemotherapy. Almost all pediatric cancer is treated by generic, off-therapy, non-patented medications. These have all been around for 50 years. So we're not trying to get the newest molecular technology or the newest CAR T cells. We don't need that to cure 80+% of patients. We had nurses who were trained in Italy in administering chemotherapy. And we had an oncologist, radiation oncologist, pediatric oncologist. We have X-ray, ultrasound, but at the time we didn't have CT scans or any other imaging modality. And that was all. Interviewing key stakeholders, patients, nurses, physicians, trying to understand why the survival rate was so low. What were the problems? So the things that most people said were cost. It was too expensive. At the time, and still, all pediatric cancer care and all cancer care is paid for by the patient. So patients have to buy their own chemotherapy. They had to buy the laboratory testing, the diagnostic testing, the transportation to and from the hospital, all of that. So it was impossible for many families to, 1, get there, and 2, afford the treatment. Patient education, most people said that people didn't know what cancer was. They didn't know about treatment. And treatment capacity, trying to improve local care capacity, so having more trained providers in pediatric protocols and treatment. So our first intervention, we started a registry. So a cancer registry, CanReg 5, that can be and has been used at KCMC and then throughout Tanzania to actually find out, so we could track what is the impact of anything that we were about ready to do. Are we going to see an improvement? We standardized treatment protocols along with Mbili, using what they had done to and other protocols that were resource adapted through SIOP, the International Pediatric Cancer Body. And an NGO provided the cost of all chemotherapy at no charge to all the patients. So that was first intervention. And what we found is there was absolutely no improvement. So that was really disheartening for us because we thought that we had sort of hit on the key problems that people were saying were the issues. We went back, again, implementation science, you're never done. You have to continually reevaluate what's happening. And what we found out is that almost half of our patients were abandoning care. If you start treatment but don't finish treatment, the likelihood of cure is almost none. We went back to try to figure out what the issues were, why people were abandoning care. Multiple things, but the one that we focused on was that patients whom it took longer than 30 days from the time they arrived at Bugando until they got a diagnosis were more likely to abandon care. Makes sense. If you're sitting there on the ward for a month, you don't have a diagnosis and you don't know why you're there, you're more likely to leave. We looked at it further. What we saw was people presented to the emergency room, tests were ordered. It took some days before the tests were paid for. Oftentimes, they had to ask for relatives to send money. Biopsy was planned, and then again, the biopsy had to be paid for and then scheduled. It took several weeks, up to a month, to get the results of the biopsy at that time. And then on day 49 is when the oncology team was notified that there was a patient with cancer. Combine that with the fact that people don't know what cancer is. It's a complex team. You need surgery, you need radiation, you need oncology. Communicating all that to families was not happening. Our goal was to figure out a way to shorten this to 2 weeks from time of presentation until we have a diagnosis, and hopefully we see them right up front to assist with this. To do that, we started a patient navigation program. So our patient navigation program, what our patient navigator does is goes on the wards, finds out, are there any patients that might have cancer here? If we identify a patient, whether it's on surgery, neurosurgery, urology, who has a swelling or something that might be cancer, we register them. We then assist with getting the laboratory testing, the biopsy, so all of that can be paid for. We do a social work evaluation to see who needs additional assistance, and then follow up the results. And our hope was that by doing this, we'd reduce the time to diagnosis, we'd reduce the abandonment, and improve outcomes. And that's in fact what we saw. So the time to oncology diagnosis, still not on day one, but after 1 year, we were down from 49 to 16 days. Time to diagnosis was cut in half, 49 down to 23 days. Treatment abandonment was reduced by 40% after 1 year. And our 1 year overall survival went from 30% to 47%, and this with a single intervention. Not quite where we want to be, but with anything, you have to continually reevaluate and go back. So things that we know are still important. Patients are coming late, as was mentioned. So we're starting to do our next phase of interventions, which will be community awareness. We started a hostel to assist with patients who are traveling, because many of our patients travel from long distances. And then we're now converting the patient navigator, so it's an app that people can use to increase adherence. We still found only a 35% adherence to the chemotherapy protocols. A lot of that is just logistics, and so we're hoping that an app and other ways to help increase adherence will work. One last thing that I want to mention is that many people always ask about the cost. I hope to impress upon you guys that the cost for pediatric care is cost effective. What we did was we evaluated the true cost of providing cancer care to children at Bugando. And this is the total cost, meaning not the indirects to the patients or the direct cost to the patient. This is the cost of the building, the cost of the utilities for the hospital, the proportion of the cost to the staff that they take care of. So basically all direct and indirect costs associated with providing care for children with cancer. So the median cost was about 5,000 international dollars. So we use that because it standardized it for everyone in the world. US dollars, that comes to like 3,000 something. So that's the cost per child of treatment, including everything. 80% of that is hospital cost. 16% was the direct cost to the patients. So 16%, which is about $800 international dollars, was the cost of the chemo, the x-rays, the biopsy, all the things that we typically think of the cost of care. Then we looked at the cost benefit. So you're looking at, for every child that you treat, how many years of life, or your daily is what it's called, do you gain? So what we found was an average of 7.9 dailies per child treated. When we looked at cost benefit, you can do it conservatively or less conservatively. No matter how you looked at it, treating a child provided money back to the government of Tanzania, almost 7 to 1. So for every $1 spent on treating a child with cancer, almost $7 would be returned, productive years, productive work back into the community. So it's an incredibly cost-effective thing. Again, we hope that that helps try to increase the ability of research in things to actually go into pediatric care and to increase interest. And we have hope that will be the case.